So I'd like to encourage you all to join the discussion and ask some questions of our most esteemed experts. They're happy to field any general questions you may have, but I'd just like to point out again, they're unable to offer any specific personal medical advice. If you have a question, please put up your hand and one of our volunteers will come by with a microphone. We're going to do it in sort of quadrants. We'll start front left and then we'll work our way around the room. So first question, let's see some hands. Okay, I will ask the first question because I got a lot of questions today. So if you guys aren't asking questions, I'm going to be. First question, and this was covered already, the importance of active rehab. Like maybe you guys could talk a little bit more about really bringing that point home. How important is that?
I guess that's me.
Is this on? Yes, it is. Well, I'm a slightly biased answer, obviously, because rehab and physical therapy is what I do. It's not just important, it is the only thing. I mean, and listening to Rhett's story is, honestly, it's sad. Where is he? He's gone. Okay. Oh, hi. Sorry. I was used to you sitting there during the presentation. And, you know, he kind of gave us a little bit of a snapshot into how many options when you're a patient. There's so, and more so than 20, 30 years ago when I started, there wasn't PRP and there wasn't ART and IMS and all these other gobbledygooks. It's really hard to negotiate as a patient when you have that sore shoulder what you should be doing. And, you know, the reality is the shoulder is dominated by muscle systems compared to the knee, where we have, you know, a small handful of muscles that control how we straighten our knee. When you elevate your arm into these very functional positions, you're engaging, you know, upwards of 12 to 16 muscles to do that, in addition to all the muscles that have to function to keep your core stable and everything else as the base of support. So it's really hard to imagine how, in your process of getting better, that doesn't need to be addressed. So it's essential. It's not sort of going to work for some people and not for others. It has to be part of it. Period.
Thank you very much.
I'm going to answer a bit of that too. I'm not a therapist, but for the elbow, when I was talking about the stiff elbow, the best thing we can do is to get the elbow moving. And Judy was mentioning that for the shoulder as well. So motion is the most important thing that we can do so that you don't get stiff elbows, stiff shoulders, stiff other joints, because the stiffness affects all of the joints. So motion is important.
I just want to bring up a little bit of a poor part of our healthcare system, and Rhett touched on it, and it's the clinical pathways. How do you access these services? You know, a guy in the NHL isn't getting guided through physio after a microfracture of his shoulder, that's what it's called, and that's disappointing. What about the public? And I have to admit, we have a lot of wasted dollars in duplications of consultations and people going to the wrong doctor and guided through the system poorly. And I think it's a huge area that we have to work on, our clinical pathways. And so motion is just one part of the piece. It's where do I go for help right from time zero? And Alberta Bone and Joint is working on that. We are trying to get intake clinics in shoulder, in knee, in elbow, and I think this is an area, though, that needs a lot of improvement and is an area that's going to be worked on in the future.
Thank you. Now let's get a question. We have a question in the back.
Thank you. Love the presentation. A lot of food for thought. I was wondering, because a lot of talk was placed on rehabilitation and work being done after surgeries or finding out what injury has happened. With all the knowledge you've presented today regarding ability to pinpoint what may happen, so what preventative measures are being taken to identify that, like through maybe a GP or something, and say, let's introduce that? And I'd like to share my example. I've had the issue of joint contracture evolving over time and getting worse. But when I went in for physio, they said, take the medication to relieve pain before you come back for treatment. And today I'm hearing that maybe, possibly, through the activity or proper guidance, I could have maybe prevented further damage. Your comments, please. Thank you.
Well, I'll address that, and it kind of goes back to my last issue of clinical pathways. And you know, someone who's developing a frozen shoulder, getting him to the right care group. And unfortunately, everyone looks at an orthopedic surgeon as an orthopedic surgeon and a physiotherapist as a physiotherapist and assume they have the toolbox for all problems, when in actual fact, most of us don't. Even though Kevin and my practices are reasonably similar. You know, we do a lot of arthroscopic surgery and it's extremity surgery, and we don't do joint replacement a lot. They're actually night and day different. And to know what pathway to go through is critical in this. And some of it, you actually have to be, as a clinician, very humble and say, I don't have the right toolbox for you, but I'm gonna find out where you go. And this even goes broader. This even goes into the school system. Who's at risk for dislocating their shoulder? Well, who's got a 5 out of 9 in their stretchy score? Maybe they shouldn't be doing back handsprings and playing hockey. Maybe they should be doing some other pathway, because even though it may be socially the thing to do, there's nothing worse to see a teenager year after year after year dealing with surgery, dealing with trauma, dealing with the repercussions of trauma, the arthritis that comes from that. And so these sorts of things, prevention right back in the youth is important.
Thank you, Mark. Okay, we got the microphone in the back right.
Oh, okay, thank you. I'd like to get the thoughts and the experience of the group relative to PRP, prolotherapy, and stem cell, if there's any experience, positive or negative, relative to that, especially for shoulder tears?
I've tried them all, and it still hurts. So, I don't. And that's the honest truth. The most recent was a stem cell, and I did it in Vancouver in February. And the first 3 weeks, I was actually unhappy with it. I thought it was expensive and maybe wasteful. But after that, for the next 4 or 5 months, I felt like my pain was diminished. I felt better. I was doing more stuff. I was sleeping better. I thought it improved it for a while, and then over the last month or 6 weeks, it seems to have been going maybe back to where it was now. Am I pushing it further and doing more stuff? I don't think so. I just feel like maybe it's wore off. The PRP, the Prolo, one of the problems that I have going back over that is a lot of that was done while I was playing. So I don't know if the benefits that you get from it were recognized, because I would go do it and then I would go play a game and bang around and mess it up some more. So maybe you guys can take over now. I don't know. Like I said, my first comment is probably my most honest. It still hurts.
I'd like to add one thing. I think that Kevin gave us a great example of a very carefully conducted clinical trial that provided robust evidence to show whether or not the treatment works. One of the challenges we have when we're talking about some of the other treatments, the treatments that are delivered in a community setting rather than in a hospital or a doctor's office setting, is the data is very dispersed. And it's very messy data in that there are so many confounding factors. So in Rhett's example, look at all of the different treatments that you had that probably are interacting when we try to study whatever the next one is going to be. And so a big challenge in really creating evidence to show the right way forward with some of the treatments is to actually gather good quality data from community care, from a physical therapy clinic, for example. We don't have hardwired physical therapy clinics into the electronic medical record system that we tend to see in a hospital setting. So it's one of our challenges going forward, but one of the great opportunities going forward is you've heard, I'm sure, about machine learning and how machine learning and artificial intelligence is a way of enabling to data mine. The beauty of this technology is it allows us to mine much more complex data sets than we've previously been able to do. And so if we can find ways of getting living labs to work in Alberta and beyond that feed data into settings where we can start to data mine, it'll start to generate data that enables us to understand the effectiveness of these treatments.
I'm just going to add a little bit. I'm actually very hopeful on biologics. Right now, stem cell therapy is like going duck hunting with a submachine gun. We are just scattering bullets in the air, drawing out fat, drawing out marrow, and letting them go. But we are studying, as Kevin's research project showed, the elements that turn off and turn on elements of stem cells. And I think we will get to a point where we are able to activate and stop and change. And it's miles away. Unfortunately, our neighbors to the south will sit in an airplane magazine and say this is a be-all and end-all cure. And just huge billions of dollars going into this in a shotgun approach. But I wouldn't abandon the hope for these being super important with future research.
Thank you.
Hi there. This is a question for, I think, the doctor in the middle that was talking about the cartilage transfers, I guess. Is it being used in any other joints, specifically maybe the hip joint? Thank you.
Yeah, in Alberta, we're using it in the shoulder, knee, and ankle. There are centers that are trying it in the hip. The hip is a deep and difficult joint to get in to, and it also is a big weight-bearing or load-bearing joint for a small surface area. So I don't know of many clinical, I think there's some research centers doing some work on the hip, but I don't know of any clinical programs on hip cartilage transplant of the same sort.
Nope.
Thank you. Getting back to the stem cell and the PRP and hyaluronic acid injections, I'm looking at the HA for my knee, which is somewhat arthritic, and as a preventative, I guess I'm asking a personal question, am I not? Sorry about that. Exit. Physiotherapy with regard to band and exercises and weights for shoulder, rotator cuff torn completely. Do you see a difference in the rehabilitation of individuals between the two?
Just to be clear, between using bands or weights?
Free weights.
My easy answer is no. I think that the factors that come into play more, resistance is resistance. Where you might fall down in terms of the effectiveness of an exercise is how well it's taught. Positioning, as an example, if we're talking about rotator cuff, for those of you that sort of have endured this, sorry, I'll get rid of my hands here. If you're doing something with a tube where you are holding a tube in one hand and this is your injured hand, you've probably seen this ad nauseum, those of you with bad shoulders. And so you can do that with tubing and the resistance, because the force and the moment arm is this way, makes sense. If you then take and hold on to a weight and do the same thing, can you guess what you're working more? You're working more your biceps, because the force now is down. And so I think that, again, in our world of copious different types of strengthening exercises and machines and equipment, I don't think it's important what it is you're using. I think it's important how well you're taught it and that you're doing it properly. And that's where I think the assistance and the effort needs to be put. So I think you can have benefits for both, from both.
I might just ask as an addendum to that. Hyaluronic acid, efficacy, effectiveness?
Out of Hamilton, Ontario, Mo Banderi did a multi-center, sort of like a Cochrane analysis, where he took thousands of papers, and that gave a large enough N to show that actually using hyaluronic acid is effective. It's more than placebo. Is it a panacea? No. But I also, kind of back to what I was stating, I think we're going to add other elements to hyaluronic acid. Lubricin, which is being developed here in Calgary. There are other components to synovial fluid. So the answer is yes, they are effective. And yes, there is some literature out of Scandinavia that they are preventative. You take 1,000 people with some arthritis, and you give half placebo, half hyaluronic acid. Whether it's the molecule or whether they're more active, 10 years later, the group that was on the hyaluronic acid had better x-rays, better function, better quality of life scores.
I get that in a bunch of joints. So.
When you were talking about the medication, I'm not sure if I'm pronouncing it properly, but the ketoprofen, I wondered, is that effective or given in someone who has a frozen shoulder? Because you mentioned it was mostly serious injuries.
It's ketoprofen. It's always a hard one to say. I've become interested in this because my interest is elbow injuries, and many people see that there's fractures. When I present this around, I get lots of people that are interested in it. After total knees, people get stiff knees, not infrequently, and so I've been working with some of my colleagues here in Calgary to see can we do some kind of trial like this. The elbow was sort of a notorious joint, supposedly, for stiffness after injury. When I was training, we used to tell everybody if you broke your elbow, you're going to miss, you won't be able to straighten it completely. But I think it affects all of the joints, including the frozen shoulder. One of the things that's relatively nice around my model, or what I'm studying in fractures, is we have a pretty good idea when the incident occurred, and there's many other things that we treat where if we can identify when this event started, then it's easier to have deciding if the medication is going to work. So with the frozen shoulder, one of the challenges will be is, well, when did this frozen shoulder start? Did it start a week ago, 4 weeks ago, a year ago? But yeah, I'd like to think that it could work in that direction too, but we don't know that.
I also just wanted to mention that after having some of those injections, I have had a few, and then only recently have they suggested going further to having physio. And I think probably because if you're not in as much pain because of the shot, then you can do more of those type of exercises and physio to help. So that was interesting to know that. The other question is the hyaluronic acid. I've also just had a Cingal injection, which has that plus another one that works fast and then prolonged, but that didn't help me. Does it have an effect depending on what actually is the injury or what is going on in the joint?
Yeah, it does. And the answer I can say is we have seen trends. About 66% of people are responders to hyaluronic acid, and the Cingal adds a little steroid to it for that initial inflammatory response that can happen when you get an HA shot. But we do see some trends. Severe arthritis doesn't respond as well as mild to moderate. Patellofemoral kneecap arthritis doesn't respond as well as the main joint. So there are some trends, but there's no black and white. I kind of feel the literature in my practice supports that. About 2/3 of patients are going to feel better, 1/3 aren't.
Thank you.
Just as an anecdote for the hyaluronic acid, for a fun story, I had a patient come to see me about elbow arthritis, and And we did use it, and she got better. And what the fun part of the story was, is it turned out I played hockey with her son-in-law, and he was happy because she was able to knead and make pierogies again. So she was very happy. They were all happy.
Good morning. For Mark Hurd, you were talking about in cartilage grafting how there was a problem with wear on the bottom end due to the weight bearing. Saw a documentary a few years back having to do with the miracle that our horses' hooves also being a collagen type structure, but it was not so much the amazing nature of collagen, but the morphology of the various planes and structures involved that allowed them to take one heck of a punishment. As yet, nature's materials of leather and collagen really haven't been improved upon much by human ingenuity. I'm wondering if perhaps we should think the stacked leather heel on a cowboy boot or a lady's shoe has been around a while. Wondering if, with the advent of 3D printing, perhaps collagen could then be horse hoof engineered into a structure that might go some way.
The research being done in engineering cartilage, meniscal cartilage, is massive, billions of dollars. And there are 3D printed meniscuses. They have tried coral. I don't know about the horse hoof, but that is interesting to, to really study something in nature. And if you go over to Barcelona and see the big church there, I'm trying to remember, Gaudi, I think it is, how he used nature for all the pillars and that, and just looking at a horse hoof and examining that further for tissue engineering. But I can tell you, industry is definitely looking at synthetic cartilage and cartilage and bone scaffolding and meniscus scaffolding. That is a huge amount of research in that.
Thank you. So my grocery list for after, you guys free delivery, 3D printed meniscus, VR gear, and the keto tiffin.
Hello, for Dr. Hildebrand, please. Your first trial, you said it was established for determining the safety of keto tiffin. What positive indicators have you had in your first trial that encouraged you to continue on with your second phase? What positive indicators did keto tiffin usage provide for you? And I have a second question after that.
When we've done the comparison about whether there's a difference between the ketotifen and the placebo group in this, there was no difference at the 152. One of the things that we found, though, in doing the study is that we probably need to narrow down the indications for what it's used in. So probably more severe injuries, and that's why we're confining it to surgery now, because we'd included everybody. And I had some colleagues that would say, well, certain undisplaced fractures of the elbow, they'll never get stiff, they just keep going. And I just saw a lady yesterday in my clinic who had one of these injuries, and she has stiffness. The problem is we think that the percentage of those people that will actually get stiff are quite a bit less than those with that have bad injuries that we need to operate on. And we've done some looking at some of the blood samples of the patients that we put into the study, the first 41, and we found those that had the needed to have surgery, and this is before they got any of the medication. They had elevated markers from these mast cells that I was talking about. Some of one of the enzymes called tryptase was significantly elevated in those that had injuries, or that had injuries that needed surgery. And we did also look if we just looked at the people who needed surgery and didn't need surgery, those that needed surgery also had stiffer elbows as a group. So that's why we came to the decision that we think we need to narrow it down to a more severe injury.
Thank you.
I have a second question, if I could, please, for Dr. Hurd. When the cartilage is replaced on your bone joint, you said there are times that the cartilage is okay, but the bone is still very fragile. Was the bone fragile underneath to begin with, or is there something associated with the injury that makes it fragile and it continues to be fragile even after you replace the cartilage? I'm just puzzled about what's happening there.
Yeah, that's a great question. The transplant, the cartilage is live. The actual bone products are dead. It's just the honeycomb. It's like finding a bone in the woods. We have that honeycomb infrastructure. If that honeycomb lattice, and it does heal to our native bone, stays structurally good, then the graft survives really well, because the synovial fluid is actually what bathes the cartilage, and the cartilage stays alive for up to 20 years or even longer. But what happens is if you impact or traumatize the honeycomb non-live bone, it can crush, like a honeycomb could be dented. And then the whole process starts to break down. The other thing we think happens is sometimes there can be a leak around the dowel, and synovial fluid can actually bring in inflammatory cells and create a little cyst and then a layer, and then it starts breaking down. So our actual problem now isn't so much preserving the cartilage and keeping the cartilage alive, it's trying to figure out how to solve the bone side of these grafts.
Thank you. We'll have time for 2 more questions. Donna?
First off, I want to thank everybody for coming today, and I want to thank all of our speakers. I just want to thank everybody for joining us today. It's really great. I mean, we have a great team that put this forum together. So thank you to all the volunteers and the McCaig Institute for all their support. And thank you to all the speakers. Now my question is, if Rhett and I walk down the stairs and we break our shoulder or our other elbow, is there a clinic in Calgary? We hear of cast clinics, knee clinics. Is there a shoulder clinic? Is there an elbow clinic in the city of Calgary that we could go to if we had an accident this afternoon?
Fractures are managed through the cast clinics, although we don't like casts too much because they make joints stiff, but we do use casts. And so with the acute injuries that have identified fractures of the bone, there are clinics set up at each of the 5 hospitals in Calgary. And actually some of the urgent care centers will look after some of the fractures that don't require any surgery. In terms of the shoulder clinics and knee clinics, there are clinics in those areas that don't treat the fracture side of things. But one of our challenges, as Mark was mentioning, is that we're trying to figure out how do we make these clinics more accessible. One person doesn't have the toolbox for everything, and we're trying to organize ourselves in a better manner that we can get to people managed quickly. It's very interesting to see the group in Edmonton, the Surge group, working on standardizing protocols. And our group in Calgary have done some research on rotator cuff tears and have shown that a well-structured physiotherapy program that's active will manage 75% of the people that actually have rotator cuff tears. So they actually have tears. Now, they're not the big, large ones that we're talking about, but so the therapy is good. Our big challenge that we're trying to organize with in our Alberta Health Services is how can we make these clinics and the providers more appropriately accessible to the people that need to be treated in whichever manner.
Can I jump in just a little bit? Because this is I alluded to a study that we're doing in Edmonton that's really, and actually it has come from the surgeons. So we're fortunate to sit around the table, a multidisciplinary group, and talk about these issues. And the surgeons really had said to us, in a day of my shoulder clinic, I am seeing a small proportion that really are surgical, that really are patients that I can help with surgery, that the large majority of them, they're having a conversation with the patient, they're asking, what's the management been? Have you had physical therapy? What have you done in physical therapy? And a huge proportion of those are being sent back to the community for physio. So let me tell you the story from a physio's perspective, where, let me tell you from the patient, because that makes more of an impact. If you're a patient who's hurt your shoulder and you see your first primary, whether it's physio or GP, what tends to be happening too much is the first order of business is ordering a whole bunch of tests, x-rays and MRI and ultrasound and all this stuff. And then patient, well, you know how quickly that happens in Alberta. So they sit and they wait for those tests for a period of time, doing nothing with their shoulder. And I'm not here to disregard GPs, because I'll tell you that my colleagues in physio are still feeling like the partial, tear, that nope, that has to go on and get imaged and managed that way. So the patient waits for 4 to 6 months for those tests, goes back, and then gets referred on to a surgeon. Well, that's not the next day either. So they wait on another list for sometimes upwards of 4 to 6 months. Then the surgeon sees them in their clinic and says to them, nope, you gotta have some good physical therapy. So then me, as a patient that's been waiting for 18 months to have something done, and then I tell them they have to work really, really hard for 3 months on their shoulder. How happy do you think that patient is? Not happy, right? Okay, I didn't expect a clap. But the problem is that, and this is why this study we're looking at, and so we have over 100 patients so far, and they are patients that enter the system, and we're creeping them. We're watching what happens to them. And so they're all doing a very active physical therapy program, and we have these intervals where we have measures where we're essentially saying, how you doing? Still appropriate for conservative management, yes or no? If they are, they fulfill the 3 months of rehab. If at some point they're going south and they're not doing well, well, then we have our expedited surgeon visit. And so of that 100, this is early, unsubstantiated results, but I see them, so I'm going to tell you. Of that 100, can you guess how many of those patients have needed surgery? So less than 10%, okay? And so the message really needs to be that if you hurt your shoulder, push for some sort of management beyond waiting on a list. And my surgeon colleagues, I'm so fortunate to work closely with them, they'll say, please, even the tears that they end up doing surgery on, those patients still benefit from some sort of active management. They do better surgically, and they do much better post-operatively. So, there's a lot of things, but we have to smooth out the system and, as Mark said, look at those care pathways so we can understand, nope, you're going to more than likely do well on this pathway, or nope, you really are that patient we need to expedite and get, so that the surgeons are having clinics that they're happier with, right? They want to see patients that they can help, not patients they can refer on, I think. Yes? That's enough for me.
Yeah. Anybody else?
No, I don't think so. In Alberta, we have primary care access to patients, so you can go and see any physical therapist you want. Now, I don't want to get into a conversation about funding, because that's going to take us down a long path. But the reality is you can access your local physical therapist without having to see your physician.
Yeah. Okay, I think we're going to shut it down there. I'd like to thank everybody for speaking. Judy, Kevin, Martin, Mark, and Rhett, thank you very much. Let's give a big round of applause for them.